Thank you for that introduction, and good morning, everyone. I would like to thank the organizers of this meeting for inviting me to speak on women's menopausal health in keeping with the conference theme, the chapters of a healthy life. Now, this subject is so wide, there's so much information to present, so what I'm going to do is an overview of menopause, and at the end of the meeting, I hope you will get a better understanding as to what is menopause, what are the signs and symptoms, is there a link between menopause and aging? Osteoporosis is an underdiagnosed disease, and as you heard, yesterday was World Osteoporosis Day, so I'll be talking a little bit about osteoporosis and how it's diagnosed and managed, and how do we manage the process so that we can get a smooth transition from our reproductive years into our golden years. And I'll talk about osteoporosis management and what kind of lifestyle changes we can make so that we can age healthy with the minimum amount of disability. Menopause is a normal, natural event. It is a final menstruation. So the diagnosis is made in retrospect because you have to stop menstruating for 12 consecutive months before you say this is it. I have known women who have stopped menstruating for 6 months. They think they're in menopause, but they are pregnant. So, and then they want to collapse when I said, no, you're pregnant. So you still have to make sure that if you don't want to have a baby at that time, that you use birth control. So, so menopause occurs as a result of loss of ovarian follicular follicle, which is usually due to aging. When women are born as little babies, we are born with about 2 to 3 million eggs. I don't know why we need so many, but that's just how it is. And then by the time we get to puberty, we have about 300,000 left. And then during the course of menstruation throughout our lifetime, we shed about 400. And then by the time we get to menopause, then, what is left, they are getting old, and then they don't respond to hormones as readily. So menopause occurs between the ages of 45 to 55. That's natural menopause. The average age is 51, but I've had 2 patients in my menopause center in Jamaica who stopped menstruating at 60. When I was getting a little bit concerned, they said, no, doc, our mothers stopped at that age, so we are not worried. Now, I'm just returning from the North American Menopause Society conference in Orlando, so as I go through the presentation, I'll give you updated information. So now we have a category where if you start menstruating between the ages of 40 to 45, it's called early menopause. And if you start menstruating before age 40, that's called premature menopause. Now, there are some women who may have had both ovaries removed at the time of a hysterectomy, or, persons who are at risk for getting breast cancer if they have the BRCA1 or 2 genes and they're opting to take out their ovaries because because some of those cancers are estrogen receptor positive, so they are sensitive to estrogen. So that means that you would have had a surgical menopause. And some women who have had chemotherapy or radiation to the pelvis where the ovaries are damaged, then that is called induced menopause. Millions of women around the world are aging. The baby boomers are aging, like myself. So in the United States, we see 6,000 women per day who are entering into menopause, and that is about 2 million women annually. Women's life expectancy is also increasing worldwide in many countries, and we heard in the Cayman Islands, life expectancy is about age 82, and in the United States, we see that it's about 80.5 years, so that means that women will be living in an estrogen-deficient state for about half to a third of their life, with all of the ramifications of that. Now, in order to understand what is happening at the time of menopause, when we have all these hormonal changes and other things that are going on, you should understand what goes on in a normal menstrual cycle. It is a complex interplay between the hypothalamus, We have 2 structures in the brain, the hypothalamus and the pituitary, that produce hormones that stimulate the ovary to produce estradiol, which is estrogen in the first half of the menstrual cycle, and progesterone in the second half of the menstrual cycle. The estrogen is responsible for lining the cavity of the womb. It gets very thick, but if it gets too thick, that may put you at risk for getting endometrial cancer in the future. So the progesterone is just to balance that. The body is always preparing itself for pregnancy, So the follicle-stimulating hormone is what stimulates the ovarian follicles where the eggs are to produce the estrogen. And then when it's time for the eggs to be shed, which is ovulation, then the luteinizing hormone is what causes the ovulation, and then the progesterone is produced in the second half of the cycle. If there is no fertilization, then that just breaks off, and that process is called menstruation, and it happens regularly, like every 28 days, or every 21 days, or every 30 days. Now, as we age, we see that the ovaries, they start to decrease in size. These follicles, go back one, please, right. These follicles, they decrease in number. These are where the eggs are. And then they respond very poorly to the FSH and the LH coming out of the pituitary. So ovulation becomes very erratic. And as a result of that, the menstrual cycle starts to get very irregular. So you start to skip months. So you'll see it come this month, and then maybe 2 months later you don't see it, and then it appears again. Now, scientists are discovering that there is an association between the age of menopause and actually how your cells are aging inside, which is called your biological aging. So we have inside of our bodies what we call an epigenetic clock, where we can now measure the DNA that has that information about how we are aging inside, and that has implications for women who have had early menopause, because we are now seeing that if you have an early menopause, it is accelerating your biological aging. The time around the final menstrual period is called the perimenopause, and it begins 1 to 2 years before the period stops, and that is called the menopause transition, and it ends 1 year after the final menstrual period. So as we said, the cycle begins to get longer, and the FSH is increasing while the estrogen is decreasing. The changes usually are gradual, but in women who have had a hysterectomy, the changes can be acute, and most of the symptoms that women get usually occur during this time. But simultaneously, many of the changes that are occurring with aging is also happening, and then after that, we call it the postmenopausal period. Estrogen acts on what we call receptors in the body. There are 2, alpha and beta, which are found in many structures throughout the body. So estrogen acts on the brain, and that is what helps us to preserve our memories. It also has a temperature regulating mechanism that estrogen has an effect on. In the breast, estrogen is responsible for the growth and development of the breast at puberty, and it also prepares the mammary glands to secrete milk in case we get pregnant. Estrogen acts on the liver, and it helps to regulate the cholesterol so that we don't form these plaques inside the coronary arteries so that we get heart attacks in the future. We saw the effect on the uterus and the ovaries. Estrogen preserves the bone and the bone mass. It acts on the vagina so that the vagina is thrown into folds. It's called rugae. The lining is sort of thickened, and it also is lubricated so that when we have sex, it doesn't hurt. The classic symptoms of menopause, the hot flash. Women ask me, "Doctor, how will I know when I'm having a hot flash?" I said, "Trust me, you will know." So we see about the changes in the pattern. When the hot flashes occur in the day, it's called a hot flash. When it occurs at night, it's called the night sweats, because you just sweat and sweat and sweat, and then you're drenched in sweat. You have to get up and change your nightgown, and then because of that, it causes disturbances in sleep. And as the estrogen levels fall, we see most of the symptoms now in the vaginal area, and then that causes pain with sex. And of course, there's a bit of a memory loss, so you're in the middle of a sentence, and you can't remember what you said. And we have poor concentration, and some women, they get a lot of those mood swings, psychological depression, and anxiety. And many women tell me that when they're leaving the house, they actually feel terrified because they can't remember if they turn off the stove, so they might burn down the house, or if they lock the door, that sort of thing. You put down your car keys, and then you can't remember where you put it. Now, in order to track what is happening with the menstrual cycle, the North American Menopausal Society, they have these little things called menonotes. So the menstrual calendar, you see all the months of the year that's there, and then now you can write down whether the flow is heavy, light, normal, or spotting. It's normal to skip periods, as we said, but it's not normal to bleed too heavy. It's not normal to bleed for like 10 days, or if you're bleeding after sex, or if the period has actually stopped, that's not normal, so you should see your healthcare provider. The hot flash, what is it? Why does it occur? The temperature regulating mechanism is in the hypothalamus in the brain. So what happens is that the core body temperature rises because it's not working properly and your body overheats. Your body cannot function if it is overheated because that will damage the processes. So we have to lose that heat by sweating. So women who are about to get a hot flash, they suddenly get this feeling of anxiety as if something terrible is going to happen to them. And then their hearts start to race, they get this palpitation. And then they feel this intense heat, usually coming up the chest, the neck, the face. And at the Menopausal Society conference last week, there was a presenter who went all around the world studying hot flashes in different cultures. And in some cultures, women feel the heat on top of their head. In like India, they feel it in their back. Some people feel it at the back of their knees, their elbows. So it's not just a traditional neck, head, and chest. And then you can see now, as the heat rises in the body, the vessels in the skin start to dilate, and then you turn red. But even when you're black, you can still see that you turn a little bit red, and then the heat escapes from the body, and you start to sweat. Now the body overcools, and then now you get cold, and you start to shiver. So imagine you sleeping at night with your spouse. This minute you have the cover on, the next minute you fling it off, and many spouses tell me, Doc, I just sleep in a different room. So you, Ben, please have a little bit of empathy. Now, the hot flashes are recurrent, but they don't last long. And as we said, when they occur by day, they're called hot flashes, and at night we call them night sweats. In some women, especially African-American women, women who smoke, women who drink too much alcohol because you know it's a vasodilator, then they usually get severe hot flashes. And now we used to think that it improves over a 3 to 5 year period, but information coming out of the study of women's health against the nation, the SWAN study, we see that hot flashes usually last for a median time of about 7.4 years. And in some women, it actually persists for life, because yesterday I was with a colleague of mine, not yesterday, the day before, and she's still having her hot flashes, and she's almost 70. So, but anyway, it decreases in frequency and intensity. Don't worry, I'll tell you how to manage that. It's not unusual for you to have sleep disturbances. Men and women, as we are aging, we don't sleep as well, but it is seen mainly in women between the ages of 55 to 64, and they have difficulty falling asleep or staying asleep. And if you're having a lot of hot flashes at night, if you have pain, like with arthritis, heart disease, mood disorders, especially depression, and for women who are overweight and obese, you may get sleep apnea, where you actually stop breathing when you're sleeping. And when you get up, you feel tired, you feel fatigued, and you get very, very irritable and antsy, and people don't like you at that time. Now, as the estrogen levels fall to below 50 picograms per mil in the blood, a lot of the symptoms are seen in the vaginal area. When estrogen acts on the vagina, you notice it's a thick layer of cells, it's thrown into folds, it has a lot of elastic fibers, so it stretches during childbirth and during sex. And then when the estrogen levels fall, you see the lining gets very thin. It's almost like a rigid tube, and it loses a lot of its elasticity. These symptoms in the vagina, unfortunately, they progress. They do not resolve without treatment. And some women, when they have painful sex, the pain is so severe that it may trigger the muscles in the pelvic floor, which is called the levator ani muscle, to go into spasm, and it gives you a condition called vaginismus. Now, at that time, the vagina just literally locks up, and it's so severe that penetration can become almost impossible. And those women, some of them that come to me, will have to use like vaginal dilators to gradually open up the vagina. So, as you can see, this can adversely affect the lifestyle of women, their sexual function, and relationships. A lot of women who have these problems, they do not talk about it because they feel very embarrassed by it, and they think that it's just an inevitable form of aging. Now, about 2 years ago when I attended an AMS conference, we decided that this term vulvovaginal atrophy didn't sound so nice. So therefore, we are trying to use a little bit of euphemism, so we are now calling it the genitourinary syndrome of menopause. I want to go back one slide. Right. We had to vote on which term we like the best. I voted for this one. So we see that women who now have GSM, that it's no longer just what is happening in the vagina. Yes, you'll see that the hair on what we call the, the hair on what we call the mons pubis becomes very sparse, and then this is the labia majora, and then it gets very thin, and the labia minora can actually fuse together, and in elderly women who are not sexually active, it can cause the vaginal orifice to close. And then the clitoris can recede, the foreskin of the clitoris, and the vagina, as we said, it gets very narrow, short, it loses its elasticity, and the skin becomes very thin, friable, and it bleeds easily. The vagina doesn't really have any glands, but we have Bartholin's glands here that produce a very thick secretion that lubricates the vagina, especially during sexual excitement, and then the urethra can get short. Pain is the most common symptom. Because of the lack of lubrication, you get genital dryness, and women get burning, irritation, and the muscles here in the pelvic floor, in the perineum, this area here, can also atrophy, and then the anus can be brought closer to the vagina, so you can see that you can get bacterial contamination getting into the bladder, and then the bladder loses its tone, and you don't empty your bladder as often as you should, or when you do empty it, you don't completely empty all of the urine. So when you get a good joke like now and you laugh and you cough or you sneeze, urine escapes. And that is called stress incontinence, and that can be very embarrassing for women. We see as the estrogen levels fall, you can see that all these symptoms of the pain increases, and then when you give just a small amount of estrogen, you can see a dramatic improvement in the symptoms. Now, when it comes to a woman's sexual interest at the time of menopause, no wonder men think that we are just out of this world, because you can see all the complex things that feed into this thing. Men are visual beings. They don't go through all of this like women. Just as we see the levels of the hormone decreasing and all of the problems that it's bringing, then we now bring in whether you have had a past history of disappointing sex, so you might have an expectation of a negative outcome. If you are not adequately stimulated by your partner, then that can also interfere with the woman's sexual desire, her libido. Some women who may have had a traumatic experience, such as if you were raped or if you were physically abused, and some women just think that sex is just for procreation, having babies, so when they have sex, they may feel a sense of fear, shame, or guilt, but at the same time, you have many women who actually enjoy a good sexual life at this time because the period is finished, so the fear of pregnancy is gone, and they feel that they're in their second spring. So it's not all woe is me. As we said, many women, you feel blue, you go through these mood swings, you feel like you're losing control, especially women who are lawyers and managers and all of that. If you have to come up here now and do a presentation, you can't be there feeling very antsy and oh my gosh, what was I saying again? I can't remember. So unfortunately, there are some women who would be more at risk for getting mood swings, and these are especially women who might have had a prior history of clinical depression. We see that as they get into menopause, it might get worse, and women who have significant stress. And now we have what we call the sandwich generation, which are baby boomers who are aging. We are not only looking after our children, but we are also looking after our aging parents. And a lot of women are losing their jobs. And when you get all these hot flashes, that can cause a lot of discombobulation in your life. It's normal to lose a little bit of your memory, which we call fragmented memory, when we age. It doesn't mean that you're getting dementia, but dementia also presents with what we call cognitive impairment. You must have at least another one of these cognitive domains in order to say that you might be getting dementia. You should be able to plan and solve problems, and you should be able to remember something that is said to you, and you should be able to understand what is being said to you. So if all of these interfere with how you interact with people, then maybe you should get tested for dementia. And then we see that we are having a session on the aging brain. It's normal to put on a little weight when we age, maybe a little 5 pounds, but we see that there's also a change in the body composition, because people say, Doctor, I never used to see this sink right here before. What's happening to me? Women actually see that your body is changing. And there is a redistribution of the fat where it's supposed to be around the hip, so that when we get a little old and frail, when we fall, then we don't get an osteoporotic hip fracture. But women who put on a lot of weight, that is mainly due to the fact that you may, your eating is not so healthy, and you should try to control that weight management. There's a lot of women who delay their childbearing because they're looking after their career, but be aware that if you start having children, please, one back. If you start having children over 45, then there is a 50% chance that you may have a spontaneous miscarriage. And of course, we have congenital anomalies like Down syndrome that increase at this time. Now, osteoporosis, as we said, is an underdiagnosed disease. This is as a result, you get a lot of thinning out of the bone in the microarchitectural structure of the bone, and then the bone gets very thin and fragile, and it breaks very easily upon minimal trauma. It is the most common bone disorder affecting humans, and we see that the National Osteoporosis Foundation says that 1 in 2 women will have an osteoporotic fracture in our lifetime. All the bones that we are going to make, we make it by the time we get to age 20, and by the time you get to 80, 30% of that bone mass is lost. It's called the silent rubber because over 95% of your calcium is in your bone. So when the calcium is needed in the blood to run different processes in the body, it just takes it from the bone and you don't feel it. The risk of a hip fracture, now this is new information, is doubling for every 5 to 6 year increase from ages 65 to 85, and there is a 20% mortality, which is associated with hip fractures. There are some ethnic groups that are more at risk than others. So if you are a non-Hispanic, white, or Asian, you're at the highest risk. And if you are a Hispanic woman, then you are at a little lower risk. But black women, we have the strongest bones. When we get osteoporosis, we actually get it at an older age. When we do get a hip fracture, we get it later on, but we die quicker because we have a lot of comorbid factors such as hypertension, diabetes, and other things that will make us die quicker. It is now recommended that women age 65 and older, that you should get a bone density test done, preferably by dual energy X-ray absorptiometry, otherwise known as a DEXA scan. And this is also new. We have a FRAC score, the fracture risk assessment, where all postmenopausal women, if you are younger than 65, and if you have a FRAC score, it can predict your 10-year risk of getting a major fracture. And the average fracture risk for healthy women is about 9.3%. So if you are over that, you should get a bone test done. There are certain medical conditions that can thin out the bone, and a lot of dermatologists use a lot of corticosteroids for treating conditions, not realizing that it's thinning out the bones adversely and causing fractures. Rheumatoid arthritis, calcium and vitamin D deficiency, and if you have already fractured a bone, especially your hip, wrist, spine, or humerus, then that is suggestive of an osteoporotic fracture. To diagnose osteoporosis, you should have a T-score of minus 2.5 or below, and if you get a T-score of minus 1 to minus 2.5, that's called osteopenia, and the normal T-score is minus 1. Next slide, please. Right. This is an interactive tool, the FRAX, and for those of you who want to see how it's demonstrated, in the interest of time, you can see me afterwards, and then I can show you on my iPhone. So when you click on this link, it takes you into the tool, and then you put in your risk factors for fracture. If you have had a DEXA of the hip, put in the BMD, and it put in your weight and height, and when you click calculate, then it calculates your 10-year risk of breaking a major bone, and if that is over 20%, you should be treated. If you have a risk of breaking your hip of over 3%, then you should be treated. Because we are treating your risk for fracture and not treating the T-score. In the past, we never used to put in the risk of getting a spine fracture. But now, in the newer machines, we have software that can measure what is called your trabecular bone score. And then when you put in that information, if it's available, it can also predict your 10-year risk of fracturing your spine as well. Now, spine fractures are more common than hip fractures, and when you have multiple spine fractures, you shrink, and then you get this hump on your back, which is called a Dowager's hump, and those fractures can be diagnosed on a lateral X-ray and also at the time of DEXA scanning, and if you lose 20% of the anterior, mid, or posterior height of the bone, then that's diagnostic of an osteoporotic spine fracture. Next one, please. Now, when it comes to managing menopause, hormone therapy is the most effective treatment for treating the vasomotor symptoms and GSM associated with menopause at any age. The benefits outweigh the risks if you take it before getting to age 60 or if you are within 10 years after menopause. The type of treatment that you use, how you use it, and when you use it will give different results. And now we have an app that the North American Menopause Society put together called MenoPro, that I also have it on my smartphone, that it can predict whether you're going to be at risk for getting breast cancer, having a fracture, or a heart attack, because that software is in there. And what we are using now is absolute risk to determine whether women can take hormones or not. So it's a free mobile app that you can download on your smartphone, and it's made for women who are 45 and older with symptoms, but people who have a surgical menopause can use it. And we have one modality for the doctor and one for the patient. And I was demonstrating it last night with some patients of mine that I used to see in Cayman. Next one, please. Right. Now, as we search for safer options for treating menopause, we are looking at what we call selective estrogen receptor modulators, such as SERMs. We saw where estrogen acts on these tissues, on these receptors. So the ideal SERM would not cause you to lose your memory and get hot flashes. So it will have a good effect on the brain, not cause osteoporosis, but we don't want the uterus, the lining, to get too thick, and we don't want you to be at risk for breast cancer or getting a blood clot. So we had a first-generation SERM, tamoxifen, which was used to, is FDA approved for the prevention and treatment of breast cancer. Then we have a second generation called raloxifene, which is FDA approved for the prevention and treatment of osteoporosis. Now we have a third generation called basidoxifene, and what they have done, they have combined it with estrogen to get the benefits of both, and now we have a new class of drugs which we are calling a TSEC, the tissue selective estrogen complex, which is ideal for women who have a uterus in. You can't take progesterone because you need it to protect the lining, and you don't want to get any bleeding, and you're having hot flashes and GSM. So ta-da, here we have a new option for you. In the WHI study, the Women's Health Initiative that caused a lot of women to throw away their hormones and said estrogen caused breast cancer, which it did not. In the estrogen alone arm, where the woman had a hysterectomy and didn't need the progesterone, after 7.1 years, there was no cancer risk. And even when they stopped it, there was a significant decrease in breast cancer. But in patients who already have breast cancer, we do not recommend that we give, oral estrogen. There are many other non-hormonal treatments for menopause. So some women may not want to take hormones, and this is the first antidepressant that the FDA has approved for the treatment of hot flashes at a dose that is a little lower than what you would normally treat for depression. And I've used gabapentin very effectively in women for treating hot flashes. Over the counter, we see so many things. We see soy, we see black cohosh, cranberries, and John's wort. So women take all sorts of things in order to get relief. Many of these just have the effect of what we call a placebo. It's as if you have never taken anything. But now we know that soy isoflavones, it is a weak phytoestrogen, so it can help with mild hot flashes. St. John's wort has been used for mild depression. And now we are using hypnosis and behavioral therapy, acupuncture, which research is showing that it's showing some promise with treating hot flashes. Next one, please. Okay. Bioidentical hormones. Women in their quest for searching for natural hormones, they are now getting all these hormones that are compounded in a pharmacy because you get a prescription from your doctor. You do a test on your saliva that says you're deficient in this or that, and the pharmacist is supposed to make up these hormones that you're deficient in. But the FDA is not approving those approaches because they are not standardized. First of all, the salivary hormone testing is not accurate, and these drugs are not tested for whether they work or not, whether they're safe, and how do you know that you're getting the same exact amount every single time? But bioidentical hormones actually they have the same chemical and molecular structure as the hormones that you're produced in the body, and many of the well-tested government-approved products are bioidentical hormones. So with GSM, if it's very mild, then you can try moisturizers that are placed inside the vagina, and you can use lubricants, but the best treatment of GSM is actually having sex regularly, because the vagina is a muscular tube, and it is said if you don't use it, you lose it. But some of us who don't have a partner, in order to prevent the vagina, remember it gets short and narrow, so you can use dilators to keep it open, but estrogen, a little bit of estrogen inside the vagina will make it come back to its premenopausal state. And of course, when we use osfemifene, that's the first SERM that the FDA has approved for the treatment of vulvovaginal atrophy. Next one, yeah. Osteoporosis, we have several drugs that are used to treat osteoporosis. The bisphosphonates were the first set of drugs that prevent the massive loss of deterioration in the microarchitectural structure of the bone. And then we have SERMs like raloxifene, as I said. Calcitonin can relieve the pain of an osteoporotic fracture, and then now we have denosumab, which is given like twice a year by an injection. The first anabolic agent, parathyroid hormone, is also given as an injection, but that is reserved for people who have multiple fractures and nothing else can treat the fracture, and it's given for a period of 2 years. So if you have already fractured, you should be treated. If you have bone osteoporosis, and if your FRAC score says that you're at risk for getting a fracture, then you should be treated. Next one, please. Now, it is recommended that women between the ages of 50 to 64, at your wellness visit, you should get your blood pressure checked at least every 2 years if it's normal. And as we said, you should get a bone density test done. Discuss that with your doctor. If you are at risk for getting heart disease and heart attack, you should get your cholesterol measured regularly. And now you can also get your coronary calcium score with CT, and it's supposed to be 0. And fasting blood glucose, if you put on a lot of weight, if you're at risk for getting diabetes, then you can do your fasting blood glucose. And if you're a diabetic, you should get your hemoglobin A1C done at least every 3 months. Mammogram starting at age 50. If it's normal, you do it every 2 years. In the Caribbean, where we may have a higher risk incidence of cancer of the cervix, like in Jamaica, we recommend that women get their pap smears annually, but in the United States, every 3 years, and if you use the HPV testing every 5 years, have your pelvic exam done every year. And for those women who are starting a new relationship, you feel like you're in your second spring, it is recommended that both you and your partner should be tested for STD, including HIV. Next one. Right. So, in order to age healthy, you need to use this time in your life to do some lifestyle modifications. Maintain a healthy weight by eating fresh fruits and vegetables, whole grains, and of course, you know, doctor's going to speak about nutrition after I'm finished. And you select healthy protein options. Every time I tell people protein, they said, but doctor, I don't eat meat. I said, I never said meat, I said protein. Because you can get protein from so many different sources: peas, beans, nuts, grains. Calcium, it is recommended by the International Osteoporosis Society that we get, postmenopausal women get 1,200 milligrams of calcium per day. Usually we recommend that you try to get it from your diet, or you can supplement. Vitamin D is necessary to absorb calcium, and it's recommended that you take 600 international units until you get to 70, and then after 70, you take 800 international units. A very good friend of mine, one of my colleagues, Professor Christopher Gallagher, he did a lot of research on vitamin D, breaking it down into ethnic groups to see how much we need, and then it is recommended that you can go up to 2,000 international units per day, but you shouldn't go over 5,000. Because what you're trying to do is to get the blood levels to about 30 picograms per mil, and they say that you don't really need to get the blood levels higher than that, because you're really not going to get, any more benefit by having a very high level of vitamin D, and it can actually be harmful. Avoid excessive alcohol consumption, try not to smoke, and then we encourage all women to exercise because we want you to institute measures to prevent you from falling down. So you do strength training, you walk with weights, and because you have to strengthen the bones and joints, because when we get older and frail, we are losing a lot of muscle mass. When children fall, they stretch out their hands like that, but when elderly women fall, they fall sideways, and that's why they break their hips. So, next one. Menopause is an important milestone because it is a new phase in our life. So therefore, we should embrace it. We should reassess our health status and our health goals at this time. Remember, every woman is unique, and different symptoms exist across different ethnic groups. We should also take into account that there are various cultural beliefs about menopause. I had a patient in Jamaica. Her son took her to see me because she thought that demons had possessed her. She had a hysterectomy, both ovaries were taken, so she had a surgical menopause, which plunged the poor woman into menopause right away. And as Bob Marley said, when you think it's peace and safe, it is a sudden destruction. I had a patch, some samples of a patch in my office, so I said to her, just stick on one of these once a week, come back in a month's time, and then I'll reassess you. And she said, praise God, the demons are gone. No. Don't laugh, because you have to, I used to look after women who were of the Rastafarian faith, so you have to respect everyone and what they believe, and if they say, doctor, I don't want this, then there are so many options that we have today that we can use to help women through this process. So therefore, when we implement these lifestyle changes, we can maximize our health moving forward. I put up this picture of this beautiful lady because this is Aunt June. She lives in Mandeville. She's 90 years old. She does not wear glasses, and she knits these beautiful handbags, and she gave me this as a Christmas present last year when she invited me to have lunch with her. She drives an SUV. She still has her driver's license because she drove me home. And not to take tales out of school, I am told that she is still sexually active. So, to me, Aunt June epitomizes healthy aging. Thank you.
Thank you. Thank you so much for that, Dr. Brooks-McKenzie. Were there any questions? Must be some questions. Got a question, hand up, and we'll bring you a mic. Anybody have any questions? No? Okay. Can we get another?
By the way, I also wanted to say if there's anyone who wants me to demonstrate how to use that FRAX calculation tool to see if you're at risk for getting an osteoporotic fracture, I also have it on my smartphone, so you can see me afterwards.
Another round of applause.